Dear colleagues,
Is
but we have to continue because now,
okay, good.
yes, we have one more dilemma, and we would like to listen to the Professor Leonard Levin from Canada. He is waiting for us, Professor and Chair of the Department of Ophthalmology and Visual Sciences, and Professor of Neurology and Neurosurgery, McGill University, Montreal, Canada. And Leon will discuss a very important and very challenging topic. Should neuroprotective therapy be prescribed if its efficacy has not yet been scientifically proven? Welcome, Leon.
Thank you, Natalia. It's a pleasure to be here. It's a fantastic meeting, and I'm surrounded by some wonderful colleagues of mine, and I'm very, very grateful for you and the committee for inviting me to this.
It's a pleasure to be here today. I am very grateful to the organizers for allowing me to lecture to you on what I consider a very important topic. Today, I will try to answer a question. Should neuroprotective therapy be prescribed if its effectiveness has not yet been scientifically proven? Fortunately, I have a fairly straightforward answer to this. Yet. Thank you so much for listening to me. I wish you well and look forward to meeting you in person someday at another meeting. Bye-bye. Of course, I'm joking. So I haven't given you a complete answer, but I can tell you to summarize a few things. To this answer for should neuroprotective therapy be prescribed if its effectiveness has not yet been scientifically proven, yes, only if all of the following are true. It's for the patient's benefit, it's safe, and you tell them that there is a lack of evidence, that you're doing this despite the fact that it's proven. You also cannot have conflicts that would give you a bias. And you understand the reason why it is worth trying. Thank you for having me here today. I'm truly grateful. Spasibo.
Thank you so much. Thank you, Leon. Let me know if we may ask you the personal question. Are you with us now online?
Of course.
Very nice. I know that you are one of the best specialists in this area of neurodegeneration, in glaucoma, optic neuropathy, and you have studied many molecules for the treatment of neurodegeneration and glaucoma as well. But tell us why we don't have any treatment until now, neuroprotection. Why is it so, and is it feasible in the nearest future that we have any medication for treatment our patient? What do you think?
Natalia, that's a very, very good question. In fact, it is the question. Just yesterday, I was speaking with some colleagues at a very large company I work with, and they asked the same question. We talked about this. And it's not just neuroprotection in glaucoma, not just neuroprotection in optic nerve and retinal degenerations. It's neuroprotection in every disease. Neuroprotection in stroke, Alzheimer's disease, amyotrophic lateral sclerosis, Parkinson's disease. There's something we don't yet understand to explain why it's so difficult to find these therapies. But I'm reminded by other diseases where people tried for many years to find a solution, and finally they did. Sometimes it goes slowly. Think about how long it took to find a way of treating HIV. It took many years, and the successful treatment required 3 different drugs together to really be successful. And look how fast it took to find vaccination for COVID, and now even treatment drugs are coming on very quickly. Sometimes it goes slowly, sometimes it goes fast. With neuroprotection, it's been very, very slow. And we go back many years and it's still slow, but at some point it will happen. I am sure of this. It's just that for some reason, is something that we don't yet understand well enough to make it happen. But there are many smart people working in this area, and I promise you at some point it will be possible.
Okay, but maybe with some new technologies, we will come closely to the decision of this problem, like drug technology, for example, or some others. I think that we have to believe and to trust for this.
Yes,
Thank
I
you,
agree.
thank you
I
very
agree with
much.
you.
Dear colleagues, do you have the questions? Thank you, Leon. Thank you very much that you gave the excellent lecture today, and I think that we have to think about this problem and be very careful with this kind of treatment, protection treatment. And now, dear colleagues, we have only 2 questions from the audience concerning the laminar cribrosa thickness. Sure, now we may measure its thickness using OCT, swept source OCT, and this will improve the diagnostics, of course. And one more question concerning the chronic ischemia to optic nerve, and of course, if we can see the signs of glaucoma, like excavation and the specific defects in perimetry, of course, we may think about the normal tension glaucoma despite the low IOP. So, and now I think that we have answered all the questions because the questions are the same. And now let me give the conclusion of our webinar and take-home messages. The first one, there is clear evidence that high IOP levels, peak IOP and mean IOP, but not IOP fluctuations, are associated with increased risk of glaucoma progression. Number 2, routine tonometry has many shortcomings. We miss peak IOP in the majority of patients. 24 hours IOP is extremely required, and the continuous IOP monitoring may improve our understanding of glaucoma progression. A water drinking test may give a hint about the peak IOP, including the patients with normal tension glaucoma. And a wide field OCT permits better understand structural functional relationship. OCTA is perspective method for evaluation glaucoma progression, but only in future due to the postponed floor effect. And the next slide, please. Initial glaucoma therapy is defined individually. It is necessary to revise the target IOP as soon as possible, and the priority of laser and or surgical treatment as the initial therapy is still to be determined. With the accumulation of scientific data, there is a need for a new classification of primary open-angle glaucoma. And we should be careful and cautious with when prescribing neuroprotective therapy. Evaluate the patient's benefits and risks, and trust only scientific data with a high level of evidence. So, dear colleagues, I think that today we have a great meeting, very nice, excellent speakers. And I would like to thank all of you who were listening to our presentations, asked the questions. Do you have some words?
It was very nice to be here today, to listen to such an honorable lectures. It was really a great pleasure. And thanks, Natalia, to organize this unique webinar. It's annual, yeah? It's every year.
Anniversary.
Anniversary, oh, yes. And I want to say, our patient, our doctors, be safe, stay strong, and take care about you and your family. Good luck.
Goodbye. Thank you.